of culture in a blood agar, we need to test for the presence of catalase and oxidase. It will be oxidase negative, catalase positive. Is a result of indole detection, citrate negative. You can see growth in Fligler iron agar with the glucose and lactose fermentation. So here are some steps, some tests used for the identification bacteriological methods. Treatment and prophylaxis includes antibiotics, bacteriophage, intestine, pyobacteriophage, that together with Pseudomonas, Klebsiella, Staphylococcus, Streptococcus bacteriophages has a bacteriophage of E. coli, and there is no specific vaccine for prophylaxis. Here was an introduction to the diagnostic clinical microbiology. I want to say that, of course, you are not bacteriologists and you don't need to know all the steps of examination, but you need to imagine the procedure. And of course, you must know principles of collecting of specimen. And you need to know the test that should be should be performed in the laboratory to examine the parasite, to examine the specimen, to identify the parasite. And you must know the time of making such diagnosis. I mean, you can't call bacteriologists just in 2 hours after collecting the specimen and sending it to the laboratory, because within 2 hours we do nothing. We can see nothing in the bacteriological laboratory. Speaking about principles of specimens collection, I want to stress, you can find them, by the way, in your manual, that choosing the specimen in opportunistic infection depends on the preliminary clinical diagnosis. That the quantity of material must be adequate. It can't be a drop of blood, for example, or drop of saliva. It should be representative for the infectious disease. I mean, when you take sputum, it shouldn't be saliva. When you examine pus, you should take it from the deep wounds, not from the surface, because in this case, otherwise it becomes contaminated with normal flora members, normal flora microbes of the skin. Well, of course, contamination of the specimen must be avoided. I mean, you should employ sterile equipment, use aseptic precautions, and of course, you should treat the surface of a skin, for example, before puncture of a wound, because otherwise it becomes contaminated with normal flora staphylococcus, and you will see them. Well, specimens must be taken and brought to the laboratory as soon as possible. And if it is not possible, transport media must be employed to let bacteria alive, to let bacteria remain alive in the specimen during transportation. Modern transport media help to leave them alive within up to 72 hours, but you'd better do it as soon as possible for prompt diagnosis. And of course, such bacteria may be sensitive to antibiotics. Not only multi-drug resistant microbes are found among opportunistic pathogens. So if you already prescribe antibiotics and it was taken already, you need to stop for a few hours, depending on pharmacokinetic of drug, just 4, maybe 6, maybe 1 day. And after that, you take specimen again. If you do it, and you'd better do it before antimicrobial drugs administration. Speaking about blood collection, of course, you realize that it should be taken using aseptic techniques with a sterile syringe after treatment of skin or in the area of puncture. 2 bottles of media must be prepared, must be inoculated. In the next slide, I will show you such bottles. They include those that are recommended for aerobic and anaerobic culturing, because anaerobes can be also responsible for blood infection, for sepsis and generalized infection caused by generalized infection. The volume of blood inoculated must be adequate. We already discussed in the lesson on enteric fevers that it must be diluted at least 1 to 10. For sepsis examination, it may the ratio may reach 1 to 150 or even 300. Why do we need to dilute blood? You know that blood contains many bactericidal substances of natural innate immunity, maybe normal immune globulins, bacterial lysins, complement, and many others that can kill bacteria if blood is not diluted. And I want to remind you that we never inoculate blood directly on the solid medium because the concentration of bacteria in a specimen is very low. And in a drop 0.1 milliliter or maybe half of milliliter that can be inoculated on the solid medium by spread technique may help to miss the bacteria, and you fail to isolate bacteria by direct inoculation of solid media. That is why prior to inoculate solid media, we need to take enrichment media for aerobes and anaerobes. Well, and the additional action, antibacterial action against innate immunity mechanisms in the blood sample is made by adding sodium SPS to culture media. Then the bottle or 2 bottles inoculated must be placed to the incubator for up to 1 week. For those bacteria are suspected as a slow-growing pathogens like Brucella that will be discussed next time, you need to wait longer, up to 3-4 weeks. Well, and according to recommendations, blood culture bottles must be examined every day, 2 or 3 times a day, for the possible presence of growth. I mean, you can see film on the surface, maybe turbidity. So if there is something wrong, it is suspected as a growth of microbes. And every day, once a day, you need to subculture specimen according to recommendations. You need to subculture specimens according to protocols into plates, into solid medium for obtaining colonies. Well, and it is mentioned here that microscopical examination is not useful because to see bacteria in a blood sample, they must reach the concentration about 10 to the power of 5. Well, and it will be severe sepsis and I think septicemia that may even kill patient. So in normal bacteremia, in typical bacteremia cases and sepsis, we never see such high concentration of bacteria. And of course, automated blood culture systems are very helpful. Here are some pictures that show you automated blood culture method, procedure of collecting blood sample and inoculation of bottles with culture media. And here is a very interesting culture medium, very useful culture medium known as a D-phase medium, because it contains both liquid phase, enrichment broth, and solid phase inside the same bottle. How does it work? After inoculation in the proper concentration, after inoculation with 5 to 10 milliliters of blood sample, it is placed into the incubator. And every day you take it, placed into incubator, yeah. And every day you take it and observe the possible, by the way, shake and let the solid phase, how to say, covered with the blood in the enrichment broth. I mean, wash or flood the surface of solid phase, and then you place it back. Once you can see colonies in the solid phase, in this step, you will open aseptically to test these colonies on the solid phase. It prevents possible contamination because, as it is recommended by the protocols, you should open it every day, right? If it is just liquid medium. But when it is D-phase medium, you can open it only once when you can see colonies on the surface. So D-phase medium is very helpful, guys, my dear. So sputum collection. Sputum collection. Here's a procedure of collection sputum recommended by CDC in United States. Well, so you can see that it is taken, by the way, it is taken early in the morning after hygienic procedure, after brushing and gargling, because you need to rinse off the microbes from the mouth to prevent contamination as far as it possible, of course, with the salivary microbes, oral cavity microbes. So this procedure is recommended to reduce the concentration of contaminated microbes from oral cavity. Well, after taking, it is taken during coughing, and it is placed to sterile container, of course. Then after that, in the laboratory, microscopical examination of sputum sample is important. We will take purulent flakes, maybe granules, maybe blood drops, and prepare smear, air dry, and stain with gram staining or acid fast staining for acid fast mycobacteria detection. And of course, you will see polymorph nuclear cells, leukocytes, because it is purulent infection. After that, you will prepare, you will perform a procedure of homogenization of sputum, because you should make it homogeneous without such flecks. To do that, you are adding 1 milliliter of sputum tested with a pipette to 9 milliliters of isotonic solution, saline, and make it homogeneous, and it will be primary dilution. And after that, you will perform culturing. A set of plates should be taken for the examination, and serial dilution method is used for sputum sample inoculation. Because to put the correct diagnosis, the predominant microbe must be identified, must be detected. And I will tell you that the concentration of bacteria above 10 to the power 6 for staphylococci and 10 to the power 7 for streptococci is helpful in making correct diagnosis of pneumonic process or suppurative process. I'll repeat that the concentration, I need to add it to my slides. I'll repeat that the concentration of bacteria isolated from the specimens, sputum specimens, above the 10 to the power 6 of colony forming units per milliliter for staphylococci, and 10 to the power 7 for staphylococci and streptococci, makes possible to put correct diagnosis, because in the concentration 10 to the power 5, we can see up to the concentration 10 to the power 5 of bacteria, CFU per milliliter, is normal concentration in oral cavity for staphyl and streptococci. It was mentioned in the lecture on streptococci. So to perform this procedure, we need to take sputum primarily diluted 1 to 10 and prepare 100 dilutions in a set of tubes with the saline, with the measured volumes. When you add 0.1 milliliters of sputum tested to the first tube with 9.9 milliliters of saline to make to bring it to the concentration 1 to 1000, because 0.1 milliliter is added to the 9.9 volume, it will be 0.1 to 10 milliliters. So it is 1 to 100 dilutions. 1 to 100 dilutions. Together with 1 to 10, it makes 10 to the power 3. And we do not subculture specimen from this tube and from the previous one as well, because it will show us just the normal flora contamination. And we go to the next to make next dilution, 10 to the power 5, bringing 0.1 to 9.9 of saline again. And we'll repeat it again, once again, to make 0.7 dilutions, respectively. So from the last two dilutions, we are subculturing specimen onto egg yolk salt agar, which is selective medium for staphylococci. It contains egg yolk to show us lysitinase activity, and it is salted medium because staphylococci are halophiles, and the presence of elevated concentration of sodium chloride inhibits the growth of contaminating microbes here. So it is selective for staphylococci. It is inoculated with 0.1 milliliter. The same volume is brought to the plate with 5% blood agar, which is general purpose medium, and it helps to maintains the growth of many microbes, and it helps to see hemolytic bacteria with alpha beta hemolysis. Yes, this is for Staphylococcus. This is for Staphylococcus, Streptococcus, Pseudomonas, and so on, because it is not selective. And the same is done for the last dilution. After 1 day of incubation, you will see the results. And you will count the number of bacteria observed on egg yolk salt agar for Staphylococci and the rest plates. For dilution 10 to the power minus 5, for example, to calculate the number of Staphylococci, you will count the number of colonies on the plate, it is N1, multiply by 10, it is a dilution factor, it is a coefficient that brings it to 1 milliliter, and then dilution factor, 10 to the power 5. It will be the concentration of Staphylococci. And 2 is for the same dilution for bacteria observed on blood agar. I think you may observe more colonies than in selective medium because it is not selective. And the same principle is applied for the last plate if they grow in the maximum concentration, maximum dilution, sorry, minimal concentration. But it will be N3 by 10 and 10 to the power 7. Open your protocol notebooks. Table 16. Table 16. Do you have? I can't see chat.
Yes, ma'am.
Okay, ready?
Yes, I have. I have. Yes.
Okay,
Just a
Paramita.
minute. Just a minute.
Just a moment, I can't. Sorry.
Yes.
Ready, ma'am.
Just a moment. Okay. Me too. Okay. This one is for sputum examination. Don't confuse. You can see pictures of tubes in there, right?
Yes,
it doesn't matter. We already discussed the procedure of inoculation, preparing of serial 100 fold
which
dilution.
table? Sorry.
Right? Yeah.
Which table?
Which
It's
table? 16. Table
It's
16.
lesson 8. It's lesson 8.
Yes.
Basic concepts.
Table
of
16 for clinical microbiology.
Yes.
Thank you.
You find it, right?
Yeah, yeah.
Sorry, 0.1. Sorry, it's the Russian variant. Well, so our plates were inoculated with 0.1 milliliter of sputum, diluted 10 to the power minus 5, minus 7, as we discussed already, right? Here's a result of growth of staphylococci on egg yolk salt agar. Can you see colonies here?
Yes, ma'am.
Can you see?
Yes.
Yes.
How many colonies
Yes.
do you see?
Yes.
1, 2,
Let's
3,
count.
4, 5, 6, 7, 8, 9, 10, 10.
10. So put down 10 colonies on egg yolk salt agar.
Yeah.
I can say 11 actually because there is one more.
11.
11
Yes,
colonies.
One is little.
Yeah, it's possible. Well, can you see turbidity zones around the colonies? Can you see? They surround. First of all, I want to stress that they are creamish or goldish, yeah, yellowish colonies. Creamish, I think, yeah, milky.
Yes.
Yes, and they're surrounded with the hello. Can you see? It is lecithinase
No,
activity.
ma'am.
No,
Yes,
it's
Right.
really small.
Try to see.
It's really small.
Yeah, because not many bacteria. That is why not many lecithinase. But it is lecithinase activity of Staphylococcus aureus. You should mention it in the protocol.
Ma'am, 11
11
colonies
colonies
of
with lecithinase activity, creamish or goldish, as you wish. It's for egg yolk salt agar. Mhm. Ready to
creamish
continue?
round, ma'am, creamish round colonies.
They're round, yes. It's typical, actually, round colonies, yes. Well, and they're creamish, surrounded with the opacity zones. Opacity zones. Opacity zones are due to lecithinase activity. It's
Surrounded
lecithinase
with
typical to
opacity.
Staphylococcus aureus.
Ma'am, what
Opacity.
city?
Opacity. Opacity. O-P-A-C-I-T-Y. Opacity zones. Or turbidity, as you wish. On your choice. Opacity zones. You should mention it is a conclusion. They're lecithinase positive. And now calculate the concentration according to formula. I will show you it again. This one. 11 by 10 and 10 to the power 5.
11 by 10 into 10 to the power 5.
Yeah. So
Anybody please calculate?
it will
11.
be, yeah, 1.1 by 10 to the
1.1.
power 7, right?
1.1 into 10 to the power 7.
7, right. So it is above 10 to the power 6, right?
Yes, ma'am.
Or we can say that it is a etiological agent.
What agent, ma'am? Excuse me?
Etiological. It is a causative agent of disease, of pneumonia. Do you follow?
Yes, ma'am.
That's good.
No, miss, can you repeat the calculation again?
Calculation, okay. 11 colonies are found in egg yolk salt agar, multiplied by 10 and 10 to the power 5, which is dilution factor. So it brings us to the first tube, right? Undiluted sputum. That's a
Yes,
concentration.
ma'am.
It is 11 multiplied by 10 to the power 6, or 1.1 multiplied by 10 to the power 7.
7.
Ma'am,
So
it's
it is
10 to the
around
power
10 to the
5
power,
or 10 to the
yeah.
power 6?
Sorry?
10 to the power 5 or 10 to the power 6?
No.
11 by 10 into 10 to the
Calculation
power
is
5.
11, 10, 10 to the power 5, right? This is dilution.
Ah, now it's,
Okay.
oh, got it.
Okay, that's good.
And now it gives result 1.1 into 10 to the
1.1
power
by 10 to the
7.
power 7, right?
Yeah.
And it is above, tenfold higher, above 10 to the power 6, right? So it is a pathogen. It is a causative agent. We can say that Staphylococcus caused pneumonia in a patient, right?
Yes.
Because I told you that it should be above 10 to the power 6. It is above.
Yeah,
Because
because it's 10 to
up
the
to
power
10 to
7.
the power 5, it is normal concentration in saliva.
Yes, ma'am.
That's good. So next plate from the same dilution is here. It is blood agar. You can see more colonies because it is not selective medium, right? But they are all hemolytic. Now let us count.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. 19, ma'am.
19, correct. With clear zones of hemolysis, you should mention it. 19 colonies, right?
Yes, ma'am.
19 colonies with clear zones of hemolysis, beta hemolytic.
Miss, which bacteria is it?
I
Streptococcus.
suppose it is also Staphylococcus. Maybe there is something else.
It's Staphylococcus.
Mhm.
That means it's beta hemolytic.
Beta
It
hemolytic,
can,
right? Yes.
okay.
it
Can
is
be any bacteria. Whatever
any
bacteria
bacteria
can do
that is
hemolytic.
hemolytic will show us such result, but they're big in size, so I cannot say that they're streptococci. It may be pseudomonas, but there are no pigments in the medium. It doesn't change the color to greenish, right? So I
Yes,
suppose
ma'am.
it is also staphylococcus. And actually, it is within the statistical mistake. I mean, it is not mistake actually, because in this plate we have 11. Here it's just 18. Within within 20, right? Say. So your calculations for blood agar, according to this formula, but actually it is similar. And you will get 1.8 by 10 to the power 7, right?
1 point, ma'am, 1
Yeah,
point?
1.9, sorry, 1.9, right? Correct.
Yes, 1.9
1.9.
into
10 to the power 7.
10 to the power 5, dilution factor, makes 1.9 but multiplied by 10 to the power 7. It's a concentration of blood agar, which is actually same for microbes. It's the same concentration. 1.1, 1.9.
1.9 into 10 to the power 7.
Yes. Then microscopic examination. Gram positive clustered cocci. Gram positive clustered cocci. They look like staphylococci, right? Under the microscope.
Is it Staphylococcus aureus?
Staphylococcus, yeah. Staphylococcus aureus, goldish pigment with lecitinase, beta hemolysis, clustered cocci, gram positive, right? Subculture on this land, growth of pure culture.
Growth of pure culture.
Pure culture, right?
Thank you,
Here
ma'am.
it is. Next step, microscopic examination of colonies for checking the purity. Again, simply clustered cocci, because for I didn't find picture with the red color for simple staining, so it's again gram staining in the picture. So simple staining, just clustered cocci.
Excuse me, ma'am.
Yes.
Ma'am, in our protocol, it's not there. It's on in number 3. It's only antibiogram.
Yeah, I was trying to
Really?
find it too. Yes, it's not present.
Yes, ma'am.
Oh, okay, no problem. No problem. Maybe I took it from the previous year album. No problem. So it will be determination of antibiogram. Actually, till now, according to these results, we suppose that it is Staphylococcus aureus, right? We don't need even checking the plasma coagulase activity because it is clustered gram positive,
Professor,
right? Lecithin is positive with the goldish pigment, beta hemolytic. So we suppose that it is Staphylococcus. So we'll stop on the step 3, determination of antibiogram. But you will do it during classes because I don't have results of our culture. Just a picture. And your conclusion, the microbe isolated from sputum is identified as Staphylococcus aureus. Conclusion, as Staphylococcus aureus. It is isolated in the concentration. You will put down 1.1 to 1.9, 10 to the power, multiplied by 10 to the power 7. Underline that confirms its etiological role in development of symptoms of pneumonia. 1.1 to 1.9 multiplied by 10 to the power 7. That confirms etiological role because it prevails. It is found in a high concentration. And the results of antibiogram will be added later during class.
Miss, is it going to be resistant to penicillin? Because remember the MRSA.
I suppose yes, but I don't know now. I suppose yes, it should be resistant actually, but maybe not.
Quarantine. After quarantine.
Thank you.
Because it is individual case, right? So we don't know. Oops, sorry. So urine sample collection. First of all, I want to stress that urine sample is collected only in cases when there is a strong evidence or suspicion of infection. So when we can see the following symptoms: frequency of urination, burning sensation during urination, dysuria, urgency, or you can see something wrong with urine, cloudy, bloody, or strong smelling, sometimes sweet odor. Or maybe if it is painful, I mean, there is a flank pain or pain above pubic area. So when we suppose that there is UTI, urinary tract infection. Well, there are 4 procedures of collecting specimens. Among them, there is only one which is non-invasive method. It is clean catch midstream urine collection. When we take midstream of urine, voiding urine. So we void first portion in the toilet, then you take sterile container and bring the rest portion, the mid portion of urine inside the container without touching, using aseptic procedures, precautions. As for the rest, the invasive method, the more or the least, like suprapubic aspiration. It is a very invasive procedure because we puncture the skin, insert the needle above the directly into the bladder, urine bladder. So it is invasive, not comfortable, of course, right? Then it may be straight catheter technique. It is also invasive, and there are problems because we can bring bacteria from distal area of urethra above to the urine bladder, for example. It will be extended infection. About disadvantage, I will tell you about disadvantages a bit later. But it is also taken with minimal contamination if it is performed properly. You can take specimen, urine directly from urine bladder, for example. And it will be for patients with indwelling catheters. It requires scrupulous aseptic technique, and it is labor intensive, I would say. So, to sum it up, both invasive and non-invasive methods are possible. Here's a procedure of suprapubic puncture. And I want to stress that in any case of taking urine invasively or non-invasively, you need to perform quantitative culture, because in any case it can be accidentally contaminated, especially when it is taken naturally or during voiding. When you perform catheterization, there is also risk of infection, and even when you puncture urine bladder, because if improperly treated the skin area, of course you can bring bacteria from the skin to the specimen. Well, in any case, I repeat, we perform quantitative cultures. Well, and I want to stress that we don't need to we don't need to keep urine sample for some time. I mean, we need to immediately bring it to the laboratory, because actually urine works as a nutrient broth, because it contains nutrients, it has neutral pH, it may contain sugars, proteins, it may contain blood, everything bacteria need. So we can't keep, we need to examine freshly taken urine sample of a patient. And of course, it should be done using aseptic precautions. Speaking about the possible disadvantages, in clean catch midstream technique, it may be contaminated with distal microbes from urethra. Well, this suprapubic aspiration is invasive and uncomfortable. And catheterization of urine bladder is also invasive and may introduce bacteria into the bladder. So it will be ascendant infection. The procedure, there are different procedures of inoculation of urine. It may be like for serial dilution method that we discussed in sputum examination. It may be deep method, deep tube method, or it may be gold technique, gold method. The procedure is following. It is similar to that you already know, but there are some differences. So you are taking plates or maybe a set of plates for culture with culture media, streak it, divide it into 4 quadrants and label A, 1, 2, 3. A, 1, 2, 3. You will draw in the protocol, there is a scheme, there is a plate in the first step. Then, with a calibrated loop, with a calibrated sterile loop, Y loop, or maybe plastic loop, you are taking portion of the urine. In most cases, it should be centrifuged portion. And in quadrant A, you are applying 40-60 sticks. 40-60 sticks without damage to agar. Then you flame the wire. Yeah.
Ma'am, will it be zigzag?
It doesn't matter actually. It may be zigzag, like it is shown here. It may be parallel sticks, doesn't matter, but you should count 40-60 sticks, many.
40 to 60.
Then, yeah. So if it is a Y loop, you will flame it in the burner, and then rotate plate a quarter turn, and you will apply 4 sticks in the following direction, overlapping quadrant A. 1, 2, 3, 4. And you'll repeat this procedure to the rest 2 parts of the plate. 40, 60, 4, 4, 4. This is the procedure of inoculation. So here's a protocol, table 17. You can see plate with many bacterial colonies in quadrant A. We can't count in quadrant 1, but we can see colonies that can be counted in here and in here. I would say we have 2 colonies in quadrant 3. And please count how many you can find here.
Over 25.
About 50, I would say. Yes, over 25. So please put down quadrant 3, 2 colonies, quadrant 2, about 50, because minute should be also calculated, should be also included. How does it help us to determine the concentration of bacteria? Look, there is table 18 in your album that helps to estimate the results. But I need to tell you first that we diagnose, if everything is properly done, I mean, urine is taken properly, You didn't keep it in the hospital in the ward before inoculation. I mean, you do it, you bring it immediately to the laboratory. So if everything is done properly, the diagnosis of bacteriuria is performed when we can see in male urine above 10 to the power 4, male urine, in men 10 to the power 4, in women 10 to the power 5. Why we can see such difference? Who knows? One more bacteria are allowed 10 times more bacteria are allowed in female urine. Who knows? Because of physiological differences, anatomical differences of urethra, right? Because, because women have a shorter urethra. So bladder is easily contaminated, right? So for male
That's
urine,
right.
10 to the power 4. For women, female, 10 to the power 5. How does it work? So if before this, we can see growth only in quadrant A, it is just contamination from urethra, right? And I can show you 2 plates. This is our plate we described, and this is another one. You can see growth in quadrant A and just 1, 2, 3, 7 colonies right here. It is already bacteriuria for both men and women, right?
Yes, right.
You can see few colonies in quadrant 1, many colonies, numerous in quadrant A. It starts from bacteriuria. It starts here from both genders, both male and female urine. In our case, we have much more. We can see 2 colonies in quadrant 3. So it is over 10 to the power 8. It is severe, I would say it is pyuria, pus in urine. So the concentration of bacteria is 10 to the power 8 per 1 milliliter per milliliter. Is that clear?
Yes.
That's good.
Yes, clear.
So let us go back and put down the results. We comment this, and then you will put down that bacteriuria is detected 10 to the power 8. Severe bacteriuria is detected 10 to the power 8 per 1 milliliter.
Ma'am, can you repeat, please?
Yes. From the beginning, quadrant 3, 2 colonies, quadrant 2 above 25, about 50. Well, and severe bacteriuria is diagnosed, is detected. You may even put down pyuria, pus in urine, pyuria.
Severe bacteria.
It is above 10 to the power 8, follow the table, above to the power 10 to the power 8 per milliliter. In most cases of UTI, we can see gram-negative bacteria from intestines because our urinary tract is easily contaminated with microbes from perineum, from rectum, from perineum, and it may be ascendant infection. So under the microscope, step 2, day 2, we can see gram-negative rods. Then subculture on the slant goes. You can see growth on the surface of slanted surface of MPA. Pure culture growth. You know, you can see uniform colonies, right? And then step 3 is determination of antibiogram. It will be shown on the class. Conclusion, the tested urine sample is non-sterile, not sterile. The isolated bacterium is identified as gram-negative rods. We didn't identify them, so we can't even imagine. Maybe it is Pseudomonas. Not sure that's Pseudomonas, but it may be E. coli or coliform. You may mention coliform bacteria or gram-negative bacteria. The concentration in the urine sample is 10 to the power 8. That confirms etiological role in development of symptoms of pyelonephritis. The results of antibiogram will be added during classes. Questions?
Ma'am,
Yes.
ma'am, you said it's severe bacteremia.
Bacteriuria, urea.
Bacteriuria. Yeah.
Bacteremia is when you can find them in bloodstream,
Yes,
blood
ma'am,
sample,
that's
right?
I
It
was
is
confused.
urea. Bacteriuria, urea. Yes.
I have a question.
Yes.
Could you send us, please, this presentation?
Actually, I'm not sure.
Because there were a lot of information.
So that is why I'm working with you.
Yes, I know, but
We can take
it would be more
screenshots.
helpful.
I'm not sure that I can send because I'm not ready to do that. Unfortunately, it is not ready till now. Maybe just parts of these demonstrations.
Okay, thank you very much.
Back.
And I have another question.
Yes, no problem.
These cards for microbiology, we have to fulfill it and to send it to our professors.
Yeah, sure. I already sent you professors' mails.
Yes, but
it was my previous, I think, letter. Yeah, try to check.
Last time, like 2 days ago, I texted to our professor for 74 and 77 group, but he didn't answer yet, and we don't know how.
Professor Pashkov is on the quarantine, so you can send me.
Okay.
So Professor Pashkov can send me papers. I will check.
Okay. Okay, we will send it to you. Okay, all right. Thank you very much.
Anything else?
That's all from my side.
Thank you. That's all for now. Bye bye.
Thank you very much.
Bye bye. Stay safe.
Bye bye.
Thank
Thank you.
Stay safe. Bye.
Bye bye.